Okay. Well, it's already, it's 9 a.m. Lima time, and we are at the hour wherever we are. So it's time to start our webinar today. Have a good day, good morning, good evening, everybody. We are starting our 17th webinar session here with NEMUS, the Network for Multidisciplinary Studies on ARV-based HIV Prevention. And let me just start by saying that last week, on 30th of September, WHO published the early release guidelines. They're updating, in fact, because now WHO is working regarding HIV guideline producing on a permanent basis. So based on updates that are published usually every year. And in this case, it was an early release guideline on when to start ARV treatment and on pre-exposure prophylaxis. No, in both cases, we can consider those are groundbreaking recommendations based on a careful analysis of evidence, and they are likely to have implications in the way national responses may be revised and strengthened around the world. Of course, it's up to the countries to evaluate how those guidelines can be considered in their own contexts, but those guidelines are based on their global guidelines, particularly for lower and middle income countries from a public health perspective, although, I mean, they at this point are relevant for all countries in the world, and it's important to discuss, to start discussing implementation issues. WHO is going to publish a specific guideline on implementation recommendations early next year. So in order to talk about all those issues, today we're pleased to have Dr. Robert Grant here with us. Bob, I mean, our friend, has more than 26 years of experience with AIDS clinical care and research, including over a decade in leading roles in international epidemiologic studies, particularly in Uganda. He was, in fact, the PI of the chemoprophylaxis for HIV prevention in men, the PrEP study in several countries. That was the first trial to show efficacy and effectiveness of the daily use of 2 antiretroviral medications for the prevention of the acquisition of HIV in gay men, trans women, and other men who have sex with men. And Bob, after discussing the implications of a new guideline, he will be sharing with us his contribution to recent WHO on PrEP implementation issues. So essentially, then we're going to talk about the new guidelines, the concrete recommendations on PrEP, and ongoing work to support implementation efforts. As usual, we'll have Bob present for a while. We'll have the chat window open for comments and questions that we'll be checking throughout the presentation. Just to avoid issues with noise and interference, only Bob's mic is open, and we'll see what we have by the end of his talk in terms of discussion. As you know, typically these sessions are recorded, so this is going to be recorded and it's going to be uploaded for other people's use after, I mean, ideally tomorrow or something like that. So anyway, I won't speak more, and I'm just pleased to have Bob take the mic and start with his talk on the new guidelines and the role of PrEP and implementation support measures. Please, Tom, thanks for being with us today. Please, Bob, go ahead.
Well, thank you, Carlos, and thank you to all of you for this opportunity to discuss the new WHO PrEP recommendations. I hope to use only about 30 minutes and leave plenty of time for questions and for discussion. Next slide. As an outline of what I'll be talking about today, we'll be talking about the dissemination of PrEP innovations as ultimately our goal for these recommendations. Recommendations are necessary and helpful, but not sufficient for that dissemination. So, really these recommendations are intended to start a discussion rather than presume to implement anything. We'll go through the new recommendations for early treatment and for PrEP. One of the most exciting things about what happened on September 30th was that under the same cover, we saw two new recommendations, one for treatment and one for PrEP. And I think it really heralds an era where prevention and treatment are fully integrated with each other. WHO evidence review is an extremely rigorous process based on a methodology called GRADE, and the results of that review always depend on what the question is. And so we talk about the PICO question, or what population, intervention, control groups, and outcomes are we most interested in. And then we'll review the evidence that was a recently completed review, and talk about a key issue for implementation, which is, who should be offered PrEP, and we've defined it as people who have substantial risk, and we understand that that needs to be operationalized. And finally, we want to discuss other implementation issues. Next slide. So, I think that the goal of this new recommendations is the appropriate dissemination of PrEP innovations, and for sure we are seeing evidence of dissemination of PrEP. Albert Liu published at the end of 2013 in PLOS Medicine evidence that PrEP as a concept was being passed from innovators to early adopters. And then by the end of 2014, we had evidence that in San Francisco, the early adopters were starting to pass PrEP off to an early majority. This kind of dissemination of innovation really characterizes all movements related to innovations, whether it's technology or hush puppy shoes or innovations in prevention and treatment. And importantly, each one of these groups of people have different information needs, different perceptions of the world. The innovators, at least in PrEP, were characterized by people who just wanted to know that it was new, that PrEP was something different from condoms or something different from PEP, and so they just wanted it to be new. The early adopters, in contrast, really need it to work well, which means that if they ask for it, they'll get it, and if they use it, it'll be highly effective. And so a typical early adopter kind of discussion is about how well does PrEP work, and you'll hear endless discussion on social media about whether PrEP is up to 90% effective, or at least 90% effective, or more than 96% effective, or 99% effective, or 100% effective, or 99.8% effective. These are all discussions that characterize early adopters. They really, really care about how well something works, and in order to adopt it, they need it to work well. Fortunately, PrEP does work well when used. Now, we are starting to see PrEP disseminate into the early majority, and that is a group that is characterized by a different set of perceptions. The early majority needs to see that other people are doing it. And so more and more in my clinical practice in San Francisco, which is both a community-based clinic called Magnet as well as an academic medical center at UCSF, for the first time this year, I'm starting to see people come in and say, I want PrEP because everyone I know is on it. That's a typical kind of statement that you'll hear from an early majority adopter rather than an early adopter. So PrEP is disseminating in one part of the world, but obviously the epidemic is global, and we need to do what we can to assure appropriate dissemination of PrEP innovations in different settings. Next slide. I just wanted to, before leaving dissemination of innovation, emphasize that it's not just San Francisco. There is evidence that PrEP is disseminating throughout the United States, and this is evidence from surveillance conducted by Gilead, looking at new PrEP starts per quarter, and this was presented at the APAC meeting this year in Miami. You can see a 332% increase in PrEP dispensations from a pharmacy database in the United States. Next slide, please. In terms of impact, you know, it's always difficult to assess impact on a public health level. We end up using ecological data, despite how complicated such data is and how difficult it is to interpret. But at least in the case of San Francisco, we're seeing that the rollout of PrEP starting in the third quarter of 2013 was associated with a 29% decrease in numbers of new cases presented. And this does correspond to a decrease in incidence measured more directly using this detuned serologic assay. Next slide, please. So what are the new So PrEP works when it's used, and there is some evidence that the technology can disseminate, at least in, it is disseminating in the United States and in San Francisco in particular. So what are the new recommendations from the WHO that, again, are aimed to try to facilitate broader and more appropriate dissemination of PrEP? Well, I wanted to start by emphasizing that the new recommendations included recommendation for antiretroviral therapy regardless of CD4 T cell count. And this is among adults greater than 19 years old. The recommendation was that ARV should be initiated in all adults living with HIV at any CD4 counts. That's a strong recommendation based on moderate quality evidence. If not everyone can be treated, the WHO is still taking the position that people who are sickest should be prioritized. ART should also be offered to pregnant breastfeeding women and continued after breastfeeding and pregnancy. So this is Plan B+, which is now recommended over other strategies for managing pregnant women and breastfeeding before and after their pregnancy and breastfeeding. Next slide. So PrEP, so the second recommendation that was published on September 30th was that PrEP should be offered to people at substantial risk. And there really was an amazing consultation bringing together diverse people from all over the world to find out what really is the question that we want to address in relationship to PrEP. And so this was very carefully worded. And the recommendation ended up being that oral PrEP containing tenofovir disoproxil fumarate, or TDF, should be offered as an additional prevention choice for people at substantial risk of HIV infection as part of combination prevention approaches. And after a very rigorous review, this was judged to be a strong recommendation with high quality evidence. And I wanted to just emphasize that this, that we thought it was important that the recommendation should be to offer PrEP, not that people should take it or have to take it. It's always a choice, and it really is a question of who should be offered PrEP. And it should be offered in combination with additional prevention choices. And instead of focusing on risk groups or key populations, we really felt that it was more important to broaden this to include everyone at substantial risk and to really encourage people working in local jurisdictions to develop their own analysis of who is at substantial risk, rather than trying to rely on very crude sort of categories of people based on demographics and sexual orientation, the way we have so much in the past. We feel that this notion of people at substantial risk is less stigmatizing than previous focus on key populations and risk groups. We also think that this allows for greater flexibility and encourages public health authorities to really understand their epidemic as best as possible. Next slide, please. So how was the systematic review performed around this key question? Well, we looked at randomized clinical trials, open label extensions, or demonstration projects evaluating the use of oral PrEP containing tenofovir. Specifically, these are regimens that either were tenofovir alone or the co-formulation of emtricitabine and tenofovir, marketed as Truvada in the United States, but it is available generically throughout the world. And so we looked at projects that aim to prevent HIV infection among people at substantial risk for HIV infection. We measured, each of the studies had to measure one or more key outcomes outlined in the PICO question, and those included HIV outcomes, safety outcomes, reproductive outcomes, and sexual practices. And they had to be published in a peer-reviewed journal or presented as an abstract at a scientific conference. Next slide, please. And these were the results in relation to PrEP effectiveness. And you can see that overall there were 10 studies that examined PrEP to placebo and involved 17,424 participants. And there was an overall reduction in HIV risk of 51%, and that was highly statistically significant. So this is all based on the intention to treat analysis. Importantly, the only interaction, so the only modifier of the effect of PrEP was adherence. If you stratify the studies, now it's important. The studies here are being stratified according to the percent in the active arm that had detectable drug. And so some studies had high proportions with detectable drug, more than 70%. Other studies had between 41 and 70%. Other studies had less than 40% of their active arm with any detectable drug. Detectable drug, by the way, doesn't mean 100% adherence. It just means they were taking, say, 1 or 2 tablets per week or more. And we see a very strong correlation here. So the more PrEP was used, the more it was effective. And that was the only significant interaction. If we looked at the mode of acquisition of HIV, comparing rectal exposure with vaginal and penile exposure, if we looked at men versus women, if we looked at younger people, meaning 24 years or less, versus older people, if we looked at TDF versus co-formulated FTC TDF, or daily versus intermittent dosing, we see really no evidence of a difference in effectiveness across these strata. And I think there's a number of important findings here that we need to consider as we move out into implementation. But the good news is that this is a very robust intervention. Doesn't matter, what sex you are or how you're exposed to HIV or how old you are. It works when it's taken. It doesn't seem to matter in this analysis whether you use tenofovir alone or co-formulated FTC TDF. These all have implications for implementation. Next slide. This is just a graph highlighting the very strong association between the proportion in the active arm of these studies that had detectable drug and the overall effectiveness. Next slide. Next slide. So when we look at adverse events, we looked at both any adverse event in the top graph as well as grade 3 or 4 adverse events across studies. You can see from these forest plots that there was no difference between PrEP and placebo in terms of these side effects. Next slide. Reproductive health is a very significant concern for broad groups of the populations that might consider PrEP. Unfortunately, we have limited information about this. The information that we do have comes from really 2 studies, FemPrep and Partners PrEP, where contraceptive effectiveness was assessed, and there was no significant difference in hormonal contraceptive effectiveness between PrEP and placebo after adjusting for confounding factors. In terms of pregnancy-related events, there was no difference in rates of reported events comparing PrEP and placebo. So what data is there is reassuring. We do understand that pregnancy for many women is a period of heightened risk of acquiring HIV, and so we think that many pregnant women who were at substantial risk before they became pregnant will continue to be at substantial risk, so we think that most of them should continue PrEP. But it needs to be a individualized discussion and decision made by the woman after consulting with her healthcare provider. Next slide, please. Drug resistance is always a concern, and you know, we tabulated and summarized drug resistance across all of the studies that had reported on this outcome. And you know, what we see is that the risk of drug resistance is mainly occurring in people who are already infected when they start PrEP. 37.5% of those starting FTC-TDF PrEP who were already infected at baseline developed an FTC resistance mutation, mainly M184V or M184I. We see it also in the placebo arm, but it's more rare. Obviously, these mutations, these mutant viruses, can be transmitted without PrEP being present. But when we look at incident infections, people who were not infected when they started PrEP, really the risk of drug resistance is very low in those receiving active PrEP. Only 3% of those who seroconverted in the active PrEP arm developed any sort of FTC or TDF drug resistance. This can also occur in the placebo arm. I think that, you know, it's important when we look at this kind of data that we weigh risks and benefits. And what we can calculate directly from this table is that FTC-TDF PrEP averted 98 infections, and that 11 infections with relevant drug resistance occurred in the active arms, 2 in the placebos, so that's an excess of 9. So we can conclude that there were 11 infections averted for every FTC-resistant case that occurred. If we look just at incident infections, then there's 24 incident infections averted for every drug-resistant infection. So if PrEP had not been provided and these HIV infections would have occurred, every one of them would have required lifelong therapy. And depending on where you are in the world, lifelong therapy involves an annual risk of drug resistance that ranges between about 5% and 20%. And so you end up with more drug resistance if you don't provide PrEP and let HIV spread than you have if you provide PrEP. So we think the risk benefit with regard to drug resistance is in favor of PrEP. Next slide. And for sure, the overall risk of drug resistance is very small. So, you know, really, we are only seeing 5 out of 9,222 PrEP users who acquired a virus that was resistant to either FTC or TDF. So, you know, this is a very low risk compared to other things that happen to people in all of our public health worlds. Next slide. You know, one key aspect of implementation is the finding from the meta-analysis that really TDF had comparable effectiveness when compared to FTC-TDF. And this was only compared directly in one study that had enough adherence to evaluate efficacy, and that was the Partners PrEP study. And you can see from these Kaplan-Meier curves that really both of the active arms did very well compared to placebo, and there was no statistically significant difference between the effectiveness of TDF versus FTC-TDF co-formulated. Next slide, please. So I wanted to summarize sort of key aspects to the consideration of TDF versus co-formulated FTC-TDF. TDF, as I said, has comparable efficacy to FTC-TDF in meta-analysis and in stratified analysis. However, we have to acknowledge that data in men who have sex with men is limited to only one study, the US safety study, that showed 0 infections during TDF use and 7 infections during placebo or deferred PrEP. This comparison was an unplanned analysis. Nonetheless, it's encouraging that TDF PrEP might be sufficient, but this is not enough evidence to drive recommendation for MSM. FTC-TDF drug costs are approximately 42% higher in Africa, and so that is a significant cost difference compared to TDF alone. And I didn't show you the data, but the risk of drug resistance is higher with FTC-TDF versus TDF. FTC-specific risk of this FTC resistance mutation called 184V or I may increase use of second-line treatment, further increasing the indirect costs of FTC-TDF PrEP. So, in addition, FTC is not registered in all countries, and specifically Brazil has never registered FTC for treatment. None of these drugs are registered for prevention except in the United States. So, you know, there may be situations where TDF is a more attractive option essentially if resources are very limited, such that the cost difference is substantial, if the medical community is particularly obsessed or worried about drug resistance. I'm not recommending that they worry about drug resistance to the extent they sometimes are, but if that is the case, then TDF may look more attractive. Or in settings where FTC is simply not available, then TDF we think is a reasonable option. Next slide, please. So I just wanted to review that the new recommendation from WHO is that oral PrEP containing TDF should be offered as an additional prevention choice for people at substantial risk of HIV infection as part of the combination prevention approaches. So the big question now is, how do we do this? What does all this mean in terms of actual programs? Next slide. And this is really what I'm here at WHO to work on is what the implementation guidance that brings together the collective wisdom of people running PrEP programs and services and demonstration projects from around the world. Notes on PrEP implementation were published with the recommendation, and I have to say that about 80, maybe half of what we're going to eventually produce has already been published with the recommendation. So you might download a copy of that and see what we're thinking. And please comment if you like it or don't. Full PrEP implementation guidance is expected in early 2016. Next slide. So, one of the key things is who should use PrEP and who should be offered PrEP. And so we need to define substantial risk. And we'd like to do that in terms of an incidence threshold. And this is a concept that Peter Gies and his colleagues presented at the WHO in March of this year. They've done some calculations showing that really the level of incidence that makes PrEP cost-saving really depends on how effective PrEP is and the relative cost of PrEP versus treatment. And if we can identify sort of what the key incidence is for cost-saving implementation, that becomes a real win for PrEP, because we can argue that that paying for PrEP and providing PrEP will save money in the end by averting HIV infections. And so this is the function of these relationships. And you can see the more effective PrEP is, the lower the incidence threshold is for cost-saving implementation. It also depends on the relative cost of PrEP versus treatment. And for sure, these concepts were also pioneered by Tim Hough's group at Imperial College. Next slide, please. So, based on, can you go back? Right there. Based on, our current assessments, we think that PrEP ends up costing about 40% of what it costs to treat an HIV case. That varies depending on a lot of things, pricing of laboratory and personnel and drugs. But we think PrEP is a lot cheaper than treating HIV, and that it's about 80% effective it's effective when used, and that we're seeing in demonstration projects that about 80 to 90% of people receiving PrEP are able to achieve protective levels. So we think a sweet spot for cost-saving implementation is about 3% or 3 per 100 person years. So what that means is that if you think you have a group that would have an incidence of 3 per 100 person years, then if you offer them PrEP, you'll end up saving money in sparing treatment costs. Next slide, please. We do see that PrEP trials have routinely been able to identify people whose incidence is greater than 3 per 100 person years. We see that in the control arm. So offering PrEP attracts people at substantial risk. And that also need to point out that HIV incidence greater than 2 per 100 person years was deemed sufficient to warrant offering oral PrEP in recommendations issued by IAS USA expert panel in 2014. The 3 per 100 person years really reflects a cost-saving threshold, in our opinion, whereas the 2 per 100 person years is a cost-effectiveness threshold, so a somewhat lower cost-effective ratio. So next slide. And this is just a table of the HIV incidence in the control arms of PrEP studies showing that many of these studies were able to identify people at substantial risk, whether we use the incidence of 2 or incidence of 3. And the more recent studies, IPREP and PROUD, really demonstrated how PrEP can attract people with very high incidence levels. Both of those studies anticipated an incidence of 3 per 100 person years, and what they actually found was 6.6 per 100 person years in IPREP and 8.9 per 100 person years in PROUD. So I think that what we're seeing here is that PrEP attracts people who need it, who can benefit from it, and that the incidence in those groups, if you don't provide PrEP, is going to be much higher than you would expect based on population surveillance. Next slide, please. I think that regardless of how you define the groups that might be offered PrEP, we need to anticipate that there's going to be enormous variation in HIV exposure within those groups, and then within each individual over time. So we do see people moving in and out of seasons of risk, and I think that really PrEP is giving us an opportunity to become very sophisticated about recognizing and understanding patterns of sexual practices, which sometimes confer high levels of exposure to HIV and at other times confer virtually none. And so we're going to likely use some sort of questionnaire or some survey that allows us to help people identify who among defined groups are at highest risk. And I like the New York State risk assessment because it doesn't require that anyone identify themselves in any particular way. And we know that that's challenging and threatening. It just asks people what they do. So it asks, do you use condoms only sometimes or not at all? Are you having sex with more than one person? Do you have sex with people whose HIV status you don't know? Are you in a relationship with an HIV-positive partner? Do you desire pregnancy with an HIV-positive partner in the past year? Have you taken PrEP to prevent HIV infection? Have you had a sexually transmitted infection? Have you used stimulants? Do you inject drugs? So none of these questions are, are you gay? Are you an injection drug users? I mean, it's really all about what you do. And people don't have to identify. I think that's really a strength of the New York State approach, and it should be adapted in other settings. Next slide, please. I wanted to emphasize that it's certainly possible that we may be overthinking how to define substantial risk, and really without much intentionality, the San Francisco experience through the end of 2014 has demonstrated that PrEP ended up being used by people who benefited the most from it. And this is the results of 3 different surveys, completely independent surveys done in the city in 2014. One was a walk-up survey, the other was a probability sample, and the other was just a convenience sample in a municipal STD clinic. And they all show a remarkable trend toward uptake of PrEP among people who had more condomless anal intercourse partners, such that 63% of men having 6 or more condomless anal intercourse partners in the last 6 months were already taking PrEP by the end of 2014, or they had used PrEP by the end of 2014. I mean, that's a remarkable uptake. And this was done really without much targeting at all. I think that most PrEP providers were providing PrEP to anyone who asked for it, after providing information about what PrEP does and what it doesn't do. And so without having these strict rules, PrEP ended up attracting people at highest risk and ended up being taken up by people at highest risk. For sure, 10 to 15% of MSM in San Francisco had taken PrEP by the end of 2014. But it wasn't in the worried well. It was in people who benefit the most from it. Next slide, please. So in terms of operationalizing substantial risk, I think we're thinking that this is a multi-tier process. One is to develop PrEP services that are attractive and conveniently located within epidemic hotspots, many of which have been mapped in our urban centers. They can be identified by age, gender, sexual orientation, but I think most importantly, they're identified by locality. Where in the city is transmission occurring? And so within those hotspots, however they are defined locally, we want to consider the enormous variability of risk within groups having a high HIV burden. And so we need to come up with locally appropriate screening questions. I think that we ought to seriously consider marketing PrEP as a way to feel safer, because it really taps into people's innate and growing ability to recognize when they may be exposing to HIV. And certainly it makes sense to be non-judgmental about sexual goals. You know, if we criticize people or judge them for having a lot of sex partners or not using condoms, then the very people that would benefit the most from our services stay away. So, you know, I think we need to find the courage to celebrate when people achieve their sexual goals, even if those goals are not our own sexual goals, or not goals that are epidemiologically or sanctioned by public health authorities. And then finally, offer PrEP as a choice to people who want it. And so this is the key to adequate adherence. I think we have a lot to learn about how to foster adherence, but what we know for sure right now is that if we provide PrEP to people who want it the most and who are motivated by PrEP rather than visit incentives or other aspects of the PrEP deal, we get extremely high levels of adherence in people when we provide PrEP to people who want it. Next slide. So we're hard at work on trying to collect and analyze clinical PrEP protocols. There's more and more that are being developed. What we have so far in the interim guidance that's already published is that we think that HIV tests should be used for PrEP that are validated for use in the local environment. And that's the most important thing. You know, we were tempted to say that PrEP requires use of more sensitive HIV tests, but then we realized that would cause people to jump to a more sensitive test before it was validated, or it would limit the dissemination of PrEP innovations. And in fact, you can see the risk benefits that even using third generation rapid tests, that we see less drug resistance with PrEP than we would see if we let those HIV infections occur and have to treat them all. So what we say is that more sensitive HIV tests are not required for PrEP, yet the more sensitive tests have multiple advantages, including earlier detection of HIV, earlier treatment, more appropriate counseling, and less risk of drug resistance with PEP or PrEP. And so, you know, as the state of the diagnostic art evolves, we're always going to be advocating for use of more sensitive tests, but always and only if they are validated for use in the local environment. We do suggest creatinine testing for renal function at baseline every 3 months for 12 months, and then every 12 months thereafter. This is because creatinine testing was used in all of the trials to start and stop PrEP. We simply don't know what would have happened if PrEP had been, if we had treated through those creatinine elevations. We are hoping that demonstration projects will be structured in a way that allow us to determine if creatinine testing is required or warranted at all. We simply don't know at this time. It's a gap in knowledge. We do recommend hepatitis B surface antigen testing at screening, and it's because of the risk of HBV rebound if PrEP is started and stopped. As most people know, Truvada is highly active against hepatitis B. And people with severe hepatitis B infection, complicated by cirrhosis of the liver, can suffer if their therapy is suddenly withdrawn. It causes an acute on chronic injury of their liver. However, we do know from limited experience from the West African PrEP study as well as IPREX that there was no risk of HBV rebound if the ALT was less than 2 times the upper limit of normal among people with who were hepatitis B surface antigen positive. But we do think that screening is appropriate because it enables HBV treatment and treatment monitoring. Next slide, please. Counseling is important. We describe principles of counseling. We think it should be brief, 10 to 15 minutes at most, client-centered, interactive, iterative, motivational, and problem-solving. That's based largely on experience from treatment settings. It's important that we say that PrEP works if you take it. Something we've learned very clearly from demonstration projects as well as ethnographic research is that people will adhere to PrEP if they believe it works. If they don't believe it works, or if they think that it works only some of the time, even if you take it, then that undermines adherence. And so really knowing the data, knowing the evidence that PrEP was highly effective when used is an important message to convey. And it does foster adherence. If we don't say it clearly, that PrEP works if you take it, if we talk about intention to treat estimates of effectiveness with people who have no idea what intention to treat is, then essentially we create a self-fulfilling prophecy where we say, take PrEP, it may or may not work for you, but we think you should take it, and that leads the person to not adhere to it, so they don't benefit from it. So you know, if we mince our words about how well PrEP works, we undermine adherence. I think we should be warning people about startup symptoms, which occur in 10 to 30%. They're typically mild and resolve by 4 weeks. They can be mitigated by taking PrEP with food or at bedtime. I think linking PrEP to a daily habit or daily routine is very important. One question I ask early on in the session is, what do you do every single day? You know, drink a cup of coffee, wake up, check your phone. And linking PrEP to something that people do every single day is a key to success in terms of adherence. In addition, I think we need to emphasize that we need a separate plan to be developed for preventing sexually transmitted infections and planning pregnancies. So there is a role for condoms, contraception, or safer conception. Please don't tell anyone that they have to use condoms. That is, by its very nature, a violent communication. You're imposing your will on them. You're also discrediting yourself, because as soon as they go out and have sex without a condom, they've proved you wrong. They didn't have to use condoms. You told them they had to, and they didn't. And obviously, they don't have to. So you don't want to set yourself up as someone who communicates in a violent way, and you don't want to set yourself up as someone who can be proven wrong the first time someone has sex without a condom. So that you must use condoms is not the right way to frame this. I think the way to frame it is to say, you know, PrEP does not prevent syphilis, gonorrhea, chlamydia, or pregnancy. What is your plan for mitigating those risks? Next slide, please. There are demonstrations projects around the world that are really going to inform the implementation guidance and best practices. We're actively thinking through and developing ways for peer-to-peer sharing of experience, of practical experience with PrEP. And so that's part of our goal at WHO, is to really facilitate peer-to-peer sharing of resources and best practices and insights. Next slide. Okay, I just wanted to end by highlighting one of the most exciting projects that I'm involved in, which is the San Francisco AIDS Foundation Magnet Sexual Health Services. They started providing PrEP. We started providing PrEP in November of 2014, and very quickly, more than 500 people have started PrEP and are being followed. We integrate both PrEP and PEP services, and that's key, because many people who request PrEP actually qualify for post-exposure prophylaxis. It's running about 10-20% of our clinic flow. PEP is transitioned with no gap in service to PrEP if risk is ongoing. Either PrEP or PEP is started on the same day of screening. So we try to get one or the other started on the same day that people darken our door. And we think that's important, because we think that many people come and ask for PrEP and PEP because something has happened. Their lives have changed. They now recognize and are willing to act on a perception of risk. We need to leverage that opportunity and get them started ASAP. Staffing is entirely nurses, and with some nurse practitioners. We have peer navigators for adherence and insurance. We have one ID specialist on call, but we don't, it gets called about once a month. Laboratory testing uses a point-of-care approach for both creatinine, that is renal monitoring, and HIV antibody testing, and we send out the hepatitis B surface antigen. Outside of the U.S., there are rapid tests for hepatitis B surface antigen. They vary in their sensitivity from about 90% to 99%. Specificity is generally quite good for those. Next slide, please. Next slide. Okay. So how to start and stop PrEP? We know that people, even at high risk of HIV infection, including this group of IPREC seroconverters. Everyone here became infected eventually, but people move in and out of periods of risk, and we're just beginning to find out about what portends the beginning of these periods and what is associated with the end. I think PrEP is really going to be an opportunity for us to become very much more intelligent about when and how and where HIV exposure occurs. We're going to look back at 2015 and say, how silly were we that all we could really say about the distribution of risk was to identify demographic groups or risk behaviors. I mean, we really are going to become very sophisticated about how sexual practices change and partnering practices change, and what are the dynamics underlying those changes. So for now, we just have to know that there are seasons of risk, and there's a lot more that we need to learn about that. Next slide. But I think we do need to be giving advice about how to start and stop PrEP. This is results that apply only for men who have sex with men or rectally exposed people, including transgender women and cisgender women, for that matter. And based on a DOT study of 28 days and modeling done by Peter Anderson's group, we think that there's 99% risk reduction after 5 daily doses of PrEP. For vaginal exposure, it's going to take more. The CDC recommended 20 days, but I know that's going to be revised as soon as additional modeling is done. So I think to start, we want people to take it 5 to 7 days before their first exposure, before they feel fully protected. And then in terms of afterwards, we think that there's greater than 90% risk reduction for 7 days after stopping drug. And again, this applies to rectal exposure. Now, what happens if someone gets exposed to HIV and didn't have 5 to 7 days daily doses before starting? Well, I think that's an opportunity for post-exposure prophylaxis. So again, we can solve that particular problem by integrating PEP and PrEP services together. Next slide. Next slide. Okay, so I just wanted to end by emphasizing that WHO issued 2 recommendations that were important. Previous slide, please. And one was related to treatment, and the other was related to PrEP. PrEP does enable treatment in several ways by having less HIV infection. People see that ARVs are safe, so the therapy is regarded more positively. ARVs are no longer associated with HIV, so less stigma. It motivates HIV testing and earlier diagnosis. It builds broader constituencies for HIV programs and fundraising. And importantly, it distributes responsibility for prevention by undermining stigma, and thereby undermines stigma, undermines criminalization, engages and empowers seronegative people, and fosters agency. Next slide, please. So, this is just testimony that PrEP users are talking about being very empowered. This is the first time that bottoms have had control over their sexual risk. Next slide. I just wanted to end by emphasizing that we have a lot that we could learn from perinatal transmission prevention, which has been so hugely successful, and they've learned so much over the last 20 years about how to build programs that can reduce HIV transmission by 90% or more. And this paper really describes some of the key lessons learned. First of all, we don't want to cut up people. We want to consider whole people who have sexual and reproductive desires. We want to make HIV testing available anytime, anywhere, anyhow. We need normative guidance. We need a review of each case to really understand what went wrong. So an each one matters review is something that's been systematized in the perinatal field. We need to do that for sexual transmission as well. We need to stop talking about this versus that strategy. We need to integrate treatment and prevention, multiple approaches. And finally, we need to foster champions and change makers wherever they occur and create compelling stories of human connection, which can lead to the end of HIV and adoption of everything it takes to do that. Next slide. So in conclusion, PrEP containing oral PrEP TDF is safe, effective, and underutilized. PrEP uptake and adherence is increasing. Substantial risk is to be defined locally. Clinical PrEP protocols are amenable to a public health approach. Next slide, please. PrEP is made possible by mostly young study participants who believe that research can improve their lives. So thank you very much. We can take some questions.
Great, Bob. Thanks for a great presentation to really summarize where we are, and this is a field that is changing quickly. We don't have a lot of time for questions, so I will go straight to them. And there are a few. One is actually about the regimes based on just TDF versus TDF-FTC. I think you already said that, in essence, comparing the few studies that compare those, two regimes in specific arms, but also the meta-analysis have defined that there's not much difference. And so the FTC, I understand, was included to increase protection, but apparently there's no, TDF alone was protective enough. So it's just one first question, and I also mentioned a second point that you might perhaps address together. There was a difference, a visible difference in the tables you showed between protection for rectal infection and protection for vaginal penile infection. No? If you think this is more or less what is happening, and why? Go ahead.
Well, the decision to include emtricitabine was actually based on an early non-human primate study, which showed that TDF alone had a disappointing level of protection for rectal exposure. That was just really 6 monkeys in the active arm versus 6 in the mock treatment arm. And it was the first series of animals that were studied by the CDC, and they had enormous sort of logistical problems to get over. And in hindsight, just how do you feed a pill to a monkey was a huge challenge for them in that first study. So anyway, the decision to use FTC was based on those animal studies, which actually were fraught with complicated methodological variation. I think that the clinical data trumps the animal studies, and the clinical data really is showing that, at least for vaginal and penile exposure, that TDF alone was highly effective. FTC also was added to the PrEP regimen because it was thought by some that having 2 drugs would create a greater barrier to drug resistance rather than 1 drug. But what one of the lessons learned is that the Truvada actually is so that the co-formulated regimen is associated with greater drug resistance than tenofovir alone, and that we've seen that with treatment as well. That HIV will evolve to become resistant to the weakest link in the regimen, even though the other more active agents are still there. So we see actually more drug resistance with co-formulated Truvada than we do with tenofovir alone. So the other question was
rectal versus vaginal penile. Yeah.
Well, there almost certainly is going to be a difference in the minimum adherence required for high-level protection for rectal exposure versus vaginal exposure. So, and it's based on the fact that tenofovir disoproxil fumarate achieves concentrations in the rectum that are 20 to 100 times greater than what we see in the blood. And that really does provide very high levels of protection for rectal exposure, even if men who have sex with men or trans women are taking only 4 or more pills per week. But in vaginally exposed women, we see infections occurring at levels of adherence that are between 4 and 5 tablets per week, which we did not see for rectal exposure. So we think that for we can hear you. So anyway, so we think that because tenofovir achieves such high levels in the rectum, there's more forgiveness for missed doses for rectal exposure. But for vaginal exposure, we think that 7 tablets per week are really needed, or at least 6. But once we get to 5 tablets per week, we're seeing vaginally exposed women get infected at a too high a rate.
And it means vaginal and also penile, or just vaginal?
Yeah, we don't really know much about penile exposure, so I'm going to be, but yeah. So
okay. All right. Then the following question is, actually you show data about daily versus intermittent, no, basically from the IPRGAY study, and while that study is very small, and the only one that has looked through this, apparently the protection was very good. So that's one point to comment. And the other question is actually about operation definitions of substantial risk. And what I was thinking is that looking at incidence implies a population level view, and how to translate that into individual assessments is complex. And obviously the New York questionnaire was an attempt to look at that. A few questions there were reasonable, but I'm with Jeff Klausner, who says that I mean, the two first questions in that questionnaire were very general. No? For example, any condomless anal sex or sex with more than one partner. No? So those two first questions were not very specific, and the others were more specific. No? So 2 points. One is daily versus intermittent, and the other one is assessing substantial risk at the individual level.
So the IPRGAY trial did show that a regimen of 2 tablets before sex, and then 1 tablet the day after sex, and then another tablet 2 days after sex was effective on an intention to treat basis in MSM. We don't think the pharmacokinetics supports that kind of regimen for vaginal exposure. We also have to think through the feasibility, the behavioral feasibility of that regimen outside of Paris-safe. And that was assessed in the HPTN-067 ADAPT trial, which studied women in Cape Town and MSM in Harlem, New York, and Bangkok, Thailand. And what we found in HPTN-067 is that the daily regimen was the preferred regimen or a preferred regimen for all 3 of those populations. It is true that in Bangkok, well, and it was preferred. It achieved the highest level of coverage of sex acts with pre and post-exposure dosing. It achieved the highest levels of drug, which provide the greatest margin of forgiveness for occasional less doses. The daily regimen was also associated with the highest level of adherence. The only exception was that we tried a time-driven regimen in Bangkok, which happened to do pretty well. But the time-driven regimen was not on-demand dosing. It was 1 pill twice a week with a post-exposure boost. And gay men in Bangkok did pretty well with that. But the event-driven dosing arm, which is most similar to IPRGAY, was not as good as either time-driven or daily dosing. So I think that for most people, daily dosing is going to be the most attractive. It is what's recommended by the FDA and CDC, by the way. And it does provide the most forgiveness for occasional missed doses. I also think that qualitative research is pretty clear that what's driving the motivation for on-demand dosing is really that people want a very clear view of how to start and how to stop. And so that's why I included in my slides this notion of how many pills you need to take before you feel fully protected and how many pills you need to take after. I think if we can provide some real guidance to people about how to start and how to stop, it's going to become less interesting to attempt non-daily dosing because of how complicated that kind of regimen is. The other people who like non-daily dosing are people who have to pay for PrEP, but you know these medications only cost about $6 a month to make and to bottle in a quality assured way. And so what I suggest to people is, rather than recommend a very complicated non-daily regimen, why don't you just ask for a discount on the drug price? And it would be very reasonable to pay a lower price rather than force your clients to do a very complicated regimen. As for the other question about substantial risk, I think it's really important that people think of this as a tiered process. The New York questions don't stand by themselves. I mean, those questions, so the first step is to identify your hotspots, figure out where your public health burden of HIV is in terms of demographics and specific localities, which blocks, which neighborhoods, and then you go to those places and then you ask your questions, because not everyone in those places is going to have high risk. And so those questions, I agree. If you ask those questions in some settings, you can end up giving PrEP to a lot of people who don't have any real exposure to HIV. So the first step is to do your epidemiology, go to the hotspots, and then you ask your questions. And then the third step is also key. You provide PrEP to people who really want it, not to people who are reluctant. You try to move them toward really wanting it if you think they need it, but you focus on, so identify your hotspots, stratify your individual risk, and then figure out who wants it.
Yeah, that's a very important difference. We have quickly 3 last questions. Can you respond to them, or you're
Sure.
Very quickly? Okay. One was actually about, from Jeff Clauser, the difference in cost between treatment and PrEP, which was supposed to be 40%. What is driving that difference in cost? Just the time, or what? So that's one, because as you said, it depends on the pricing, the number of drugs, etc. The second question from Don Colby is about the possibility of recommending PrEP to people below 18 years old, because, for example, in Thailand, that's a group with extremely high incidence. And finally, Jeff again asks about offer of PrEP in which settings. That's an implementation question. No? So in the guidelines for implementation, what kind of ideas are being discussed about where to offer, in which circumstances? So I say this again. One is about the difference in cost between treatment and prevention. The second is gay men below 18 years old. And the third is about where to offer PrEP.
So the difference in cost between PrEP and treatment are differences in the cost of drug regimens, the differences in laboratory testing costs, and the difference in treating of complications. Treating a PrEP complication, by the way, you just stop PrEP. Treating an HIV treatment complication typically involves a lot of work, including figuring out how you're going to treat lung cancer and heart disease and these things. So, but the main difference in the cost of PrEP and treatment is the cost of the drugs. And laboratory testing. In terms of less than 18, so let's admit there's no published or presented data in PrEP among people less than 18. We do know that these drugs are safe from the treatment experience, and we see comparing young adults with older adults that when used, PrEP is effective. So if the incidence is higher in less than 18, I think PrEP should be offered, and I think the implementation guidance from WHO is going to recommend that PrEP be used in anyone who's at substantial risk. But we do acknowledge that there is a need for more information from younger populations, especially how to combine PrEP with the comprehensive social and health services that young people need and want.
Where to offer PrEP?
Yeah. Sexual health clinics, reproductive health clinics, family planning clinics, HIV specialty clinics if there's capacity to deal with seronegative partners, and general practice, I think are all leading candidates. We're seeing the greatest success in sexual health clinics. Adding PrEP to a clinic that's already treating syphilis and gonorrhea and chlamydia is relatively easy. It doesn't really take much extra effort or testing. And family planning clinics would be the other sort of low-hanging fruit. Ultimately, I think this, like all prevention care, should be provided within the context of general medical practice. PrEP is proving to be a gateway drug to primary health care. People who have had no interest in establishing a relationship with a doctor suddenly show up to the clinic where they're diagnosed with diabetes or uncontrolled hypertension or reflux disease or a variety of medical problems that can be managed. But they just weren't severe enough, in their view, to warrant seeing a doctor. Now they're in primary care. So, it's general practice is, I think, the ultimate goal. But what we're seeing right now is that the implementation of PrEP is easiest in the setting of sexual health services.
Okay, great. Thank you very much, Bob. We had Dr. Robert Grant discussing the new WHO guidelines regarding particularly regarding PrEP and implications around the world. It's been a very useful discussion. I think we need many of these. As for this one, we have recorded it. It's going to be uploaded on our website and distributed with our listserv as usual. So, Bob, thanks again. I mean, we confirmed this last week, and so thank you for being amenable to that, and we'll announce the next webinar soon. Thank to you all for your participation. Thank you. Bye.
Thank you. Thank you, everyone. Carlos. Yeah.
Bye. Take care. Bye.